There are certain common specific tumors which occur in our day-to-day life where we observe because of the exposure to the environment, or otherwise because of hereditary disorders, or otherwise it could be because of any infections induced. So certain specific tumors, among them there could be, one of them could be squamous cell papilloma. Squamous cell papilloma, it is usually a benign epithelial tumor, that is which is of epithelial of origin, and it is benign tumor, slow growing tumor, and which does not spread. And usually we see that this benign tumor, it involves certain particular areas, and amongst these areas they could be mostly it is the areas which are being exposed to the environment, and they are the skin, lip, oral cavity, pharynx, larynx, esophagus, cervix, vagina, as well as the anal canal. So these are certain areas where we see that the squamous papilloma most commonly involves. And usually based on certain other investigations and certain observations of on culture of the biopsies, it has been observed that few of the papillomas, they have been associated with viral in origin. Among the viral species, it was of the human papilloma virus 6 as well as 11, which have been most commonly involved with this papilloma, and they have suggested that this could be one of the etiological reasons for the papilloma to develop. And most commonly seen age groups for the squamous cell papilloma to occur, it is in 30 to 50 years of age group, and the regions, it is the buccal mucosa as well as the tongue and lips when it's related to the oral cavity. These are the most commonly involved areas. Among the lips, it is most commonly the lower lip and the mucocutaneous region. Usually it appears as just as an outgrowth which measures 1 to 2 centimeters in diameter, and it is a circumscribed area with the normal surface appearance, and the patient might have not any problem exactly with this tumor, but rather it interferes with during eating, and results also in if the tumor is large enough in the buccal mucosa or in the palate or otherwise in any oral cavity regions, it might cause difficulty in swallowing, thereby any accidental trauma might result in painfulness of this papilloma. So histologically, what we observe it gives finger-like projections of the papilla can be seen. So that is the reason it is called papilloma, because of the finger-like projections of the epithelium which outgrow, and this within this outgrowth we also see there is parakeratin which is being occurring accumulation can be seen. Other than that, we also see within the epithelium that there is acanthosis, that is swelling in the spinous layer of the swell because of the enlarged cells, as well as loss of the intercellular bridges can also be appreciated. Other than that, we can also be in this picture that they have been separated as nodules, these increased parakeratitic regions, and there's inflammatory cell infiltration as well as certain collagenous tissue can also be observed. Usually patient is not advised for any treatment, but suppose because of the aesthetic region, a patient might be supposedly advised for a laser treatment or excision can be done. Other than that, if there's any discomfort with like surface alteration with such kind of tumors, then patient is advised for topical application of salicylic acid compound. Coming to the next common tumor, it is a basal cell carcinoma. Most commonly, it is a kind of ulcer, that is so it is known as rodent ulcer because it gives a appearance of a rodency on a superficial surface. And other than that, it is most commonly seen affecting the individuals who are being exposed to the sun, and also in certain regions where there's increased in the temperature, such as say in countries like New Zealand, we see that these patients are most commonly affected, and most commonly involves the white when compared to the black racial species. And usually the nature of this basal cell carcinoma, it is usually locally invasive and slow growing tumor, and rarely it metastasizes to the underlying connective tissue. And usually it is seen in the areas such as regions where there is hairy skin region, say suppose the face region, it is most commonly involved, and most commonly it is it occurs in the region where there is where there is a line which connects the tragus to that of the corner of the lip. Any region between this can be most commonly affected. So face, it is the most commonly affected region, which constitutes of 90% of basal cell carcinomas occurs in the facial region. Coming to the gross appearance of the carcinoma, usually they could be either a nodular ulcerative type, or otherwise that is they might show ulcerations along with certain nodule formation, or otherwise they can be only ulcerated type of nodular pattern. That is, they could be only of nodular pattern without any ulcerations, or also they can show pigmented type because of the based on the expression of the melanin pigment to the exposure to the sun. They might result in pigmented type of basal cell carcinoma, or otherwise it might also be fibrosing variant, that is the normal epithelium being replaced by fibrous tissue. Coming to the histological features of the basal cell carcinoma, usually we find there is an increase in the keratin, that is here in the picture we can appreciate proper increase in hyperkeratin, so it is known as hyperkeratosis can be seen. Sometimes there is also even hyperorthokeratin, that is when the nuclear remnant are being present within the keratotic tissue, then it is known as orthokeratin. And we can see that there is thinning of the epithelial layer. There is also a excessive proliferation of the epithelial layer can be seen, which results in irregular retipec formation. And there is increase in the fibrous tissue with certain cystic regions can be seen, that is spaces can be seen. There is also collagenous tissue with numerous blood vessels, and certain muscular tissue can also be associated, since it is usually just beneath the skin, so certain intramuscular region can also accommodate within this tissue. So these are the histopathological features what we can observe in the present picture. Coming to our next common specific tumor, it is the adenoma. Usually it is a benign tumor of epithelial tissue which shows a glandular origin, or otherwise a glandular characteristic, or otherwise it might show both the origin as well as the characteristic of a gland. Usually the growth it shows of it's seen most commonly occurring in the glandular organs, that is in any kind of glands, and it involves only in the epithelial tissue, does not enlarge and extend to the connective tissue. And usually certain adenomas may turn into carcinomas, they might undergo malignant changes and result in the formation of adenocarcinomas. Usually it shows a mass effect, that it involves both the epithelium and connective tissue when it involves the malignant stage, and it is also associated with certain paraneoplastic syndromes, that is of the if it involves a pituitary gland or the adrenal gland, it might be associated with those syndromes also. So adenomas, they usually are based on the location of what they involve. They have been classified into colon adenoma, that is which involves the intestinal colon, and if it involves the kidney, it is known as renal adenoma. If it involves the adrenal gland, it is known as adrenal adenoma. If it involves the thyroid gland, it is known as thyroid adenoma. And in case of pituitary gland, pituitary adenoma. In case of parathyroid gland, it is known as parathyroid adenoma. In case of liver involvement, that is known as hepatic adenomas. In case of breast involvement, it is known as breast adenoma. In case of bronchial or pulmonary involvement, it is known as bronchial adenoma. And in case of sebaceous region involvement, that is within the sweat glands, it is known as sebaceous adenoma. And if it involves the salivary glands, that is known as based on the involvement. If it is major salivary gland, that is known as major salivary gland tumor. If it is a minor, it is known as minor salivary gland adenoma. Coming to the histological features of a general adenoma of a gland, we see that if it is a histopathological picture showing that of a salivary gland tissue, where we can see numerous serous as well as mucous cells along with the adenomatous formation with various degrees of cellular dysplasia of pleomorphism as well as altered nuclear cytoplasmic ratio. And usually these tumor cells, they form the glands, that is they induce the gland formation, or otherwise structures which are related to the gland, that is otherwise they might induce the acinar cell formation, or otherwise the duct-like formation can also be seen. And these tumors, they might be pedunculated, that is they might consist of a stalk with proper stalk and formation of a proliferation of the tissue, or otherwise they might be sessile, that is they might be attached without to the underlying structures without any interconnecting structures as seen in the pedunculated type. Coming to the adenocarcinoma, which is also a specific tumor which involves a major saliva, usually it is a carcinoma of the salivary glands, and that to the minor salivary glands. We see that it involves most commonly the age group of 50 to 79 years, and females are more commonly affected when compared to males in a ratio of 2:1. And clinically what we see is it is a swelling which occurs firm and it is non-tender, that is not painful, and most commonly involved regions, it is in the palate as well as in the cheek and upper lip. These are the areas which are involved with adenocarcinoma. Other than that, patient might also manifest with bleeding and telangiectasia, that is dilated vascular channels can be seen. Otherwise, there's ulceration of the overlying mucosa associated with adenocarcinoma can also be seen. Usually, a patient is advised for wide surgical excision, that is removal of the tumor intact can be suggested. Coming to the histological patterns, usually we see it could be a solid pattern, that is these cells, tumor cells, they might be occur in the form of sheets or otherwise in the form of islands or cords can be seen, and ductal pattern we see they are arranged in the form of tubular pattern in the two-row form can be seen. In the cystic pattern we see that there are numerous cystic spaces present within the adenocarcinoma. In the tubular pattern we see that they are arranged in the form of rows and they form tubules like structures. In the cribriform pattern, we see that they are flattened cells with interconnecting duct-like structures can be seen. So these are certain patterns of adenocarcinoma. And the tumor stroma, when we stain for specific stains, then we see that it stains positive for the mucoid tissue and shows a hyaline-like appearance can also be seen. Because of the fusion of the collagen tissue, it gives an hyalinized appearance. And usually we see that the characteristic feature of adenocarcinoma is it can infiltrate to the underlying tissue and result into a malignant form, and it can also invade into the perineural areas, showing a perineural kind of invasion. This is a picture, histopathological picture being stained with H&D stain, showing numerous presence of acinar cells. They are both the mucous cells as well as the serous cell can be seen. Other than that, there are even certain cystic kind of spaces can also be seen within the histopathological picture. Coming to our next common specific tumor, it is the fibroma, which is a most common benign tumor which is seen involving the oral mucous membrane of a patient. And usually it occurs usually from the physical trauma or otherwise from the prominent or continuous cheek bite can also result in the formation of this fibroma. Usually we see that it appears as a pedunculated mass which is solitary in appearance, and it is discrete as well as superficial to the oral mucous membrane. In cases of it has been classified as a benign tumor when it is constitutes of only of fibrous tissue or the connective tissue. It is known as true fibroma when it is occurs as an uncommon tumors in a soft tissues. So it is usually appears as a hyperplastic fibrous tissue when compared to that of the true neoplasm. And usually the patient is not advised for treatment, but suppose it's really disturbing the patient during chewing or otherwise during speech like conditions, then patient is advised for removal, that is excision can be done of the tumor. Histologically, as the name itself suggests, it is a fibroma. It consists of a fibrous growth. Other than that, we also see certain underlying connective tissue elements known as mesenchymal tissue elements. We see that is of three types, that is a fibroma durum type, fibroma mole or fibroma lipoma or soft fibroma type, or elastofibroma type. Fibroma durum type, that is it involves the superficial regions. Fibroma lipoma type or soft fibroma, when it involves also the underlying adipose tissue, it is known as fibroma lipoma type or mole type. It is so called when there are even any melanin pigment cells which are being associated with this fibroma. And elastofibroma type, it is so known when there are any elastic tissues being included within this fibrous tissue growth. So this is about fibroma. Coming to next, fibrous sarcoma, that is it is a tissue, it is a tumor which is of slow growing type, and it usually involves when the connective tissue is being involved in case of fibroma, that is superficial epithelial tumor only consists to the epithelium. When it invades into the underlying mesenchymal tissue, it is known as a fibrous sarcoma, and most commonly it is seen in age group of 4th to 7th decades of life. And the regions involved, they are the trunk, head, neck, retroperitoneal region as well as the extremities. It could be the lower extremities or otherwise the upper extremities. And usually since it's a sarcoma, that is a malignant tumor, it has a property of metastasis which usually spreads through the bloodstream, that is a hematogenous route. So this is a fibrosarcoma. Usually we see that there's numerous neoplastic cells can be seen, that is tumor forming cells which are of varied shape. They are mostly of spindle shaped, round shape, oval shape, or otherwise the arrangement of these cells can be given in a herringbone pattern. That is, they give a fish scale type of appearance. There is a picture, histopathological picture, showing the herringbone pattern of arrangement of these neoplastic cells. Other than that, we also see within the neoplastic cells there is even connective tissue stroma in the form of collagens which can be seen. Other than that, we also see fibroblasts and certain blood vessels can also be seen associated with fibrous sarcoma, and certain atypical features of mitotic figures, altered nuclear cytoplasmic ratio, altered nuclear size, cytoplasm ratio, cytoplasmic structure might also be increased, giving an anisocytosis or poikilocytosis appearance can also be seen, which are all of a atypical or dysplastic features usually seen in a malignant tumor. Coming to our next more specific type of tumor, it is known as lipoma. It is usually a common soft tissue tumor which involves the adipocytes, and usually it is seen superficially grown tissue or tumor, showing the it occurs as a single or solitary lesion which is soft and it is movable and is usually a painless mass and has a property of slow growth, and most commonly involved age group is 4th to 5th decade of life shows this type of involvement of lipoma. And coming to the gender predilection, it is most commonly involved in the females when compared to males, and usually it is seen in the subcutaneous tissues, that is in the neck or otherwise in the back or otherwise in the shoulder regions. And rarely lipoma can transform into liposarcoma, which is say about is less than 1% of the tumors of lipoma may turn into a liposarcoma. Gross specimen, usually we see that the tumor, it is since it's composed of an adipose tissue, it is usually soft to firm in consistency, and it is a well circumscribed area which does not show any nodular formation or any ulcerated kind of formation, and it appears quietly yellowish, pale white to yellowish or orange type. So this is a gross specimen which usually shows that it is a circumscribed tumor showing firm to hardened consistency, and also showing the measurement that it is widely an enlarged or excised lesion which has been excised intact. Coming to histopathological features, usually we see that the lipoma, it could be a fibrolipoma type, that is it might involve in the connective tissue region and show numerous fibrous tissue growth with the formation of collagen tissue as well as certain blood vessels also. Coming to angiolipoma, when it is seen involvement of the blood vessels, then it is known as angiolipoma. That is also known as infiltrating or intramuscular type of lipoma, when it is seen the lipoma being involved within the muscle tissue, or it could be a myelolipoma also when it is seen involving the marrow activity. That is a spindle cell lipoma, when histopathologically when we observe that the lipoma upon the histopathological features we see this presence of numerous spindle shaped of adipocyte cells, that is known as spindle cell lipoma. And it is known as pleomorphic or atypical lipoma when it shows varied range of morphological changes and with minimal atypical features. So there is a histopathological pictures. We see that they appear as empty spaces because since lipid is dissolves during the processing of histopathological processing of the tissue, and and it is more lipid soluble solvents which are being used during the processing. So the lipid is completely dissolved and it gives an appearance of an empty spaces, and the nucleus is being pushed completely away from the center of the cell and gives a pycnotic type of appearance. And other than that, we also see certain muscle tissue involvement here in this histopathological picture. This is about lipoma. Coming to liposarcoma, already said that there are only certain less than 1% of the lipomas which might transform into liposarcoma, and it could be, if it is a sarcoma, then it is the most common type of soft tissue sarcomas, showing presence of origin from the primitive mesenchymal cells or from the lipoblast cells, and people from 5th to 7th decade of age group are most commonly involved. These liposarcomas usually they are deeper, but whereas we have seen that in the lipomas they are superficial and they are mostly of intermuscular regions. These liposarcomas, they usually spread to the lungs and other certain visceral organs or the serosal surfaces. Since metastasis is a feature of malignant tumors, they have a property to spread to these areas. So usually we can differentiate a liposarcoma into well differentiated type when they usually resemble that of the cells of origin, that is of the mesenchymal origin or the lipoblast origin, that is known as a well differentiated liposarcoma. It can be said as a myxoid liposarcoma, say when it shows the connective tissue region or the sarcoma region, which shows a myxoid appearance of presence of cartilaginous tissue, bone tissue as well as connective tissue region or the fibrous region, then it is known as myxoid appearance. When the tumor cells, that is the say they could be, if it is a lipoblast cell or the mesenchymal cell, they give an appearance of a round cell, then it is known as round cell liposarcomas. Otherwise these mesenchymal cell might appear as round cells. That can be said as a pleomorphic when they show wide range of appearance of varied morphological structures of the neoplastic cells. So these are certain histopathological pictures. This histopathological picture of the liposarcoma shows the presence of numerous lipoblasts which have been grouped together and they are of various morphologies. Other than that, we can also see there is presence of proper connective tissue septa which is being separating these interspersed neoplastic cells of the liposarcoma. And usually coming to the prognosis, usually within the well differentiated liposarcoma and the myxoid type of variant of the liposarcoma, they should have an excellent prognosis, but it has a poor prognosis in case of pleomorphic liposarcoma, since pleomorphism is a atypical feature or a dysplastic feature of a malignant tumor. So this is about liposarcomas. Coming to the certain disease of the oral cavity. Usually we find Lichen Planus, which is a common oral cavity disorder. It is said to be, rather than an oral lesion, it is a mucocutaneous disorder. That is, it involves the mucous membranes as well as the cutaneous tissue, that is the skin tissue. So it is seen most commonly in the females when compared to that of the males in a ratio of 1:4, 1.4:1 is to 1. So coming to the regions where most commonly Lichen Planus is involved, it is the buccal mucous membrane or the buccal membrane, which is a buccal mucosa, which is most commonly involved. Followed by this, it is the tongue, then the lips, then the gingiva, then the floor of the mouth and the palate, which are most commonly involved. Coming to the clinical features, we see the patient usually gives a history of presence of white patch-like distribution which can be seen, and it is painless kind of tissue which is being seen, or an overgrowth which can be seen. And this condition, it can be termed as trio of Wickham when there's any clinically it can be termed when we see that they are radiating or interlacing white strand-like structure from a central elevated dot of this white patch, that is known as trio of Wickham, which is a clinical feature observed in oral as well as skin mucous as well as cutaneous type of Lichen Planus. Coming to the clinical variants of this Lichen Planus, it might appear reticular, that is along with certain reticular type of pattern, that is interlacing strands of pattern appearance, then it is known as reticular type of oral Lichen Planus. Suppose when it is of erosive type, then it is known when there is constitutes of a proper erythematous base along with and raised margins, then it is known as erosive type of oral Lichen Planus. When if it is papule type, that is where we see patch-like appearance which is slightly elevated from that of the surface membrane of the mucous membrane, that is known as papular type of Lichen Planus. Plaque type, when it is a proper patchy distribution of this white appearance, then it is known as plaque type. Atrophic type, it is so termed when this plaque type it is being atrophied or completely removed and results in a blood-like blood discharge or red areas, erythematous areas, then it is known as atrophous type. Bullous type of Lichen Planus, it is usually a term when we find there are fluid-filled vesicle types or any fluid which is being observed within this white patchy area, then it is known as bullous type of Lichen Planus. Coming to the etiology, usually it's of an unknown etiology, but based on certain investigations, they have been observed that it is a T-cell mediated autoimmune reaction. That is, an autoantibodies, they are being formed against certain keratotic cells or otherwise certain epithelial cells or squamous cell which contain this keratohyalin pigment. They are autoantibodies formed with to these cells. So this could result in a T-cell mediated autoimmune reaction and result in oral Lichen Planus. Coming to the histopathological features of oral lichen planus, usually we see that it could be a hyperkeratosis or hyperorthokeratosis. That is, so it's known as hyperkeratosis when there's increase in keratin and there's no presence of any nuclei present within the keratin tissue. If it is orthokeratin, that it means the nuclear membranes are being retained from the parent cells. That is, as we know, oral mucous membrane shows a maturation from the basement membrane, basal membrane cells to the superficial, where they eventually lose their nucleus. But when this nucleus is being retained, it is known as hyperorthokeratosis. So this is what the picture, the first yellow arrow shows that the presence of hyperkeratosis can be seen in the superficial layer. Next coming layer, it is within the spinous layer, the red arrow mark, which indicates that the histopathological features, they show the presence of acanthosis. That is, there's increase in the size of the spinous layer because of the increase in the size of the spinous cells, and thereby when this condition is being observed, we can also observe proper intercellular junctions which are usually present connecting that of the spinous cells with that of the adjacent cells. These junctions are known as desmosomal junctions. So this what is the arrow which indicates that the presence of that is acanthotic cell is being marked, and in this spinous layer showing acanthosis can be seen. Next layer, it shows that next blue arrow mark, the dark blue arrow mark, it indicates that the retipex formation. Usually we see that the retipex, they usually they unplug or embed into the connective tissue, and they result in a formation of retipeg or reti-rich formation when the connective tissue is being enclosed within this epithelium. But here in lichen planus, we see there is no retipeg formation, proper retipeg formation alike with that of the normal epithelium. So this is what the picture here shows, histopathological picture. There is only presence of one retipeg here, which is being indicated with a dark blue arrow mark. Coming to the next histopathological picture, we usually see presence of Max Joseph spaces, which is also one of the characteristic feature of lichen planus, but it is not a characteristic feature of the disease, but it is a artifactual picture or artifactual space which is being created during the laboratory procedure of a processing of this oral lichen planus tissue. Since the junction between the epithelium and the connective tissue is being weakened here in oral lichen planus, since it's an autoimmune mediated reaction, and during the improper holding of the tissue, this results in a proper space between the epithelium and connective tissue, and this results in Max Joseph spaces. This is so-called Max Joseph spaces because it was coined by the person who has identified this space. And the black arrow mark here indicates the presence of Max Joseph spaces. Coming to the next feature, we see a subepithelial band of inflammatory cell infiltration, chronic inflammatory cell infiltration here in lichen planus, which is also one of the characteristic histopathological feature of lichen planus. This is being indicated with a sea green arrow mark, sea green color of arrow mark. We see that numerous lymphocytes, that is a chronic inflammatory cell infiltration, which appear to be just present immediately beneath that of the epithelium. That is, it's like hugging of the subepithelial band of inflammatory cell infiltration with that of the epithelium. Coming to that, other features what we see is, we see there's presence of numerous collagenous tissue, presence of blood vessels, as well as certain fibroblastic tissue can also be observed. So these are the features what we observe within the lichen planus. That is, there is also presence of certain connective tissue features, presence of normal fibroblasts, collagenous tissue, as well as certain blood vessels. Another important feature is presence of cuvate bodies. They are the colloid bodies which are seen within the lichen planus tissue. So this is what is about lichen planus. Coming to next common oral cavity lesion, it is a stomatitis. Usually it is a inflammation of the mouth and the lips, so it is known as stomatitis. And the cause, it could be because of the nutritional deficiency. Nutritional deficiencies can also result in stomatitis, or otherwise anaphthous ulcers, which are known as which might also result in stomatitis, or otherwise it is known as angular stomatitis when it involves the commissures of the lips, or otherwise in cases of dentures being utilized by the patient can also result in denture induced stomatitis. Migratory stomatitis, it is a condition where we see in case of benign migratory glossitis, that is a geographic tongue, where we see there's atrophy or inflammation of the tongue, which also known as migratory stomatitis. It is also a condition where we see in stomatitis. Otherwise, in chemotherapy and radiotherapy, they are actually known as mucositis, because after chemotherapy and radiotherapy, patient might result in hypersalivation or decreased in the levels of saliva, and this might in turn cause inflammation or result in formation of ulcers, and this is known as stomatitis. This is also one of the reasons for stomatitis to occur. Other than that, we also see certain other condition known as chronic ulcerative stomatitis is also a condition where we see when it is associated with gastrointestinal disorders. Coming to the next common oral cavity lesion, it is a leukoplakia. It is usually a predominant white lesion of the oral mucosa which cannot be characterized otherwise as any other definable lesion. So it is we see that the patient shows increased presence of white patch. This is because of the keratosis, and this keratosis, it appears white because of the reflection of the light, and rather since it's being underlaid with proper blood vasculature, it should appear red in color because of the light reflection property. Also, we find it as white in color when viewed clinically. So it is a firmly attached white plaque or a patch which appears on the mucous membrane. Mainly there are two clinical variants: homogeneous leukoplaque, that is, it appears as completely as a white appearing plaque, whereas non-homogeneous or heterogeneous plaque, when it is associated with certain erythematous areas and an abnormal or another differentiating color, that is with a light yellow color base and raised border, then it is known as non-homogeneous plaque. So coming to the major causes, it is majorly it is seen in tobacco-induced causes. It could be because of the smokeless tobacco or otherwise the smoking tobacco, which might result in formation of leukoplakia because they alter that of the keratin formation because of the smoke, and also it is because of the reverse smoking condition can also be seen for this. Other than that, alcohol can also be condition. Alcohol alone cannot be the condition, but alcohol in synergy with that of the tobacco habits can result in leukoplakia formation. UV radiation can also be induced. That is, exposure to the UV radiation, ultraviolet radiation, can also be one of the cause for leukoplakia to be developed. Candida is one of the species which can also result in formation of this white plaque. Since candidiasis is a condition where we see it is a similar white patch formation can be seen, but in candidiasis this patch cannot be rubbed off, whereas in leukoplakia it can be rubbed off. These are the differentiating features which we see in candidiasis thrush and leukoplakia. And since leukoplakia can also be because of the alteration in the tumor suppressor gene known as TP53 gene. Suppose any patient is being exposed to any irradiation, and this results in the damage in that of the progenitor cell, and this is not being repaired by the tumor suppressor gene, then this mutation from the basal cell might continue and prolong to that of the daughter cells and result in the formation of abnormal cells which produces keratin and results in hyperkeratosis, resulting in leukoplakia-like patch. So these are certain etiological factors which might result in leukoplakia. So coming to the features of leukoplakia, usually we see there's hyperkeratosis which can be seen in the leukoplakia. Other than that, we can also see acanthosis can be seen. That is a second arrow mark which represents the acanthotic cell. That is a cell which shows acanthosis with a central nucleus and peripheral halo. That is the cytoplasm is being lost. Other than that, a prominent intercellular bridges can also be seen. And there's improper arrangement or disorganization of the lower basal cell region can be seen. They are usually tall columnar cells which are properly arranged, but they are disorganized. And there is even abnormal arrangement in the entire epithelium can be seen. There's abnormally enlarged retipex can also be appreciated in these cells, with underlying chronic inflammatory cell infiltration can be seen, and certain dysplastic features like atypia can be seen, abnormal nuclear cytoplasmic ratio, abnormal size of the nucleus, as well as abnormal size of the epithelial cells can be seen. Presence of numerous mitotic figures can also be seen. in the such conditions of leukoplakia. Since it's a potentially malignant lesion, it has a more chances for turning into a malignancy if it is not cured or if the habits are not being withdrawn from the patient. So this might result into a malignancy. Coming to our next commonly seen is squamous cell carcinoma. It is a carcinomatous condition, that is, it's a malignant tumor or malignant lesion of the oral cavity. It occurs usually with a very good poor prognosis, which is when it is not recognized and treated when it is in an initial stage only. So it is comprises of 90% of all the oral malignant tumors, and it is comprised of 5% of all the body tumors. And it varies among the regions. In UK and USA. It appears in a age group of 55 to 75 years of age group, whereas in India it appears in an age group 40 to 45 years, probably because of the habits among the patients. And that is in the because of the changing lifestyle, patients are more exposed to tobacco, alcohol, hookah kind of things, which might result in development of the normal lesion into fast growing or progressive lesion and result in a carcinoma. And usually, as already said, their habits are more prominent in conditions like India, Sri Lanka and eastern countries. So there is increased occurrence of this squamous cell carcinoma at an early age among these regions. And most commonly it is males when compared to the females. Because of the induced habits, this gender predilection can be seen. The most common areas where we see involvement, it is firstly it is at the lips, then followed by this it is the tongues, then is the floor of the mouth, then the buccal mucosa and the palate, which are most commonly involves intraoral regions. Coming to the etiological factors, it is strongly associated with tobacco smoking and tobacco chewing as well as chronic alcohol consumption, and it can be virally induced also with human papilloma viruses 16, 18 and 33 type. And whereas weak association, that is these which are usually less involved for the squamous cell carcinoma to develop, it is a chronic irritation, that is when the irritation is progressive in nature, that is it could be because of the dentures or because of the or dislodged restorations. This might also result in, or a prominent cheek biting might result in squamous cell carcinoma. Other than that, the submucosal fibrosis, conditions such as oral submucous fibrosis, might also turn into a squamous cell carcinoma. And Plummer-Vinson syndrome, which is a deficiency disorder because seen in vitamin A deficiency with esophageal web formation and cricoid disorders, might also be one of the reasons for it to progress into squamous cell carcinoma. Coming to the morphological features, clinically it might appear as an ulcerative type showing manifestation as an ulcer, or otherwise it might appear as a papillary or verrucous type. Here in the picture where we see that it is outgrowing, that is a tumor which is mostly outgrowing into a papillary projections, finger-like projections, or otherwise abnormal verrucous type projections. And it could also be nodular type, that it could be a solitary nodular type, which might, where the neoplastic cells they proliferate in the form of nodules, or cirrhosis type can also be appreciated. Coming to the histopathological features, usually squamous cell carcinoma based on the degree of differentiation of the anaplastic cells and also presence of certain other features of typical minimal atypical features. It can be differentiated in 3 types: well differentiated type, moderately differentiated type and poorly differentiated type. Coming to the well differentiated type, usually we see that this tumor, it shows minimal atypical features of very few mitotic figures and increased keratin pearl formation can be seen, and negligible nuclear and cytoplasmic atypia can be seen in these patients, can be seen of well differentiated type, and it has a very good prognosis and can be treated in an earlier state, and probably the lesion can be resolved completely in these patients of well differentiated type. Coming to the moderately differentiated type, we see that these cells, they do not have a proper resemblance with that of the parent cell as that of in the well differentiated type, but they might show only few resembling features with that of the parent cells of the epithelial cells, and other than that, there are even keratin pearl formation and presence of mitotic figure formation, and also invasion of these neoplastic cells into the underlying connective tissue stroma can also be appreciated. Coming to the poorly differentiated side, we can properly appreciate a proper breach of the epithelial tumor cells progressing into the underlying mesenchymal cells with severe morphological atypica can be seen. That is, they are the cells. They have various pleomorphic shapes as well as increased abnormal mitotic figures, and increased mitotic figures can also be seen in such cases. This is known as poorly differentiated type. So this is what is about squamous cell carcinoma. Coming to dental caries, usually this is dental caries. It is a condition where we see that there's destruction of the calcified tissues of the teeth, that is of the enamel as well as of the dentine we see. And usually when a patient consumes water intake with that of 1 parts per million of fluoride, then this condition might reduce that of the DK type, and there's reduction in that of the rate of dental caries. Coming to the etiopathogenesis, how dental caries occur. Usually when a diet which is composed of refined carbohydrates is being taken and is not being properly cleansed from the mouth, and this results in a sticky form of tissue of food which is being retained within the mouth, and this sticky form of retained food, it might cause it might combine with that of the saliva, and also with that of the persisting normal levels of the acidogenic bacteria which are the normal residents within the oral mucosa. And all of these together, that is the carbohydrates, that is the sugar, saliva, and as well as the bacteria, all of them together they combine and release certain organic acids. So these organic acids, they usually result in decalcification of the enamel and dentine. That is, they remove the calcium part of the enamel matrix and dentine matrix, thereby causing the compromised structure for the stress, and thereby on progressive mastication forces or otherwise progressive action of the bacteria along with the carbohydrate, it might cause complete dissolution of this enamel matrix and dentine matrix and result in the formation of a cavity known as dental caries or dental cavity. So morphologically, the changes what we see clinically are usually in the initial stage when there's any caries attack, we see that this formation of small chalky white spot which can be seen on the enamel. Then this small lesion, it might enlarge in size and result in progressive changes in the color. That is, it might turn into yellow or brown color because of the continuous activity of the refined carbohydrates with the saliva and the acidogenic bacteria, and they result in the formation of cavity because of the tooth structure. It is being decalcified, and this caries cavity results into a larger cavity because the enamel is being completely fractured, and just below the enamel we see that there's a dentino-enamel junction which interconnects the enamel with that of the dentine, and this results the enamel dentine junction is also being reached by this carious activity, and which might also cause harm to this DAJ, and this also ultimately results in dentine destruction. And then when its dentine is being destroyed, it might result in progressive nature of this caries and cause even the treatment might also be progressive. That is, treatment for a chronic condition is being given then for the treatment of an acute stage. So there is a picture showing, the first picture, that the caries is being only up to the enamel. Then the next picture showing the caries involving the enamel dentine layer and reaching into the dentine. And from the dentine, it might also cause, this might progress into the pulp and result in, if this progresses into the pulp, it might result in infection of the pulpal tissue. And from the pulpal tissue, if it is still progressing, then it might result in an abscess formation, and complete infection of the tooth can result. So coming to the sequelae of caries, it usually involves pulpitis, that is, it involves inflammation of the pulp, that is, a pulp tissue is being affected, and if this pulpitis is not being treated, then it may result in a formation of a granuloma, which is composed of an inflammatory cell as well as necrosed tissue at the apical region of the tooth. So it is known as apical granuloma, and this apical granuloma, further, it is the granulation tissue is being replaced by a cyst-like formation and results in abscess formation. It is known as apical abscess. So this is what is about dental caries. Coming to dentigenous cyst, there is also a progression from a dental caries or an apical abscess might have a property to progress into certain other cysts also. Coming to dentigerous cyst, it is usually a cyst being seen enveloping that of an unerupted tooth. It is known as odontogenic cyst because this cyst usually arises from an odontogenic follicle. Odontogenic means tooth forming tissues are known as odontogenic. And since this cyst is being associated with that of the odontogenic tissue, it is known as odontogenic cyst, and this usually surrounds the crown of an unerupted tooth. And this cyst, it is formed by a fluid which is being accumulated between the reduced enamel epithelium, that is a epithelium, that is a follicle which is being surrounding that of the unerupted tooth, and that of an enamel of an unerupted tooth. So this is a area where the fluid is being accumulated, and it results in a cyst formation in which the crown is located within the lumen. Usually dentigerous cyst, it comprises 20% of all the jaw cysts and 10% of all the impacted teeth. And most commonly involved dentition, it is a permanent dentition when compared to that of the deciduous dentition. And the teeth most commonly involved here are the mandibular third molar third molar teeth. Then followed by this is a maxillary third molar. Then is a maxillary cuspid teeth. These are the teeth which are most commonly involved. Coming to the radiological features, usually upon radiological examination, we find the dentigerous cyst, it could be either of the central variety, that is the radiolucency accompanying only the which can help us in identifying the cyst, that the cyst is only accompanied with the center of the tooth. So there is known as central variety. Suppose because of the pressure of the cystic fluid, this cyst might sometimes, or otherwise because of the eruptive forces, this cyst might either be pushed to at one edge of the tooth, and then that time it is known as lateral variety. Suppose because of the eruptive forces as well as because of the masticatory forces, and because of even of the shedding forces of the tooth of the deciduous teeth, this might also result in a circumferential variety, that is the cyst or the expansion which is completely enveloping that of the unerupted tooth. It is known as circumferential variety. So these are the radiological features which can be observed or appreciated with that of a dentigerous cyst. Coming to the morphological histological features, usually we see that this presence of reduced enamel epithelium, that is, it is a epithelium which appears flattened in appearance. Other than that, we also see certain appearance of presence of certain other Rushton bodies. They are also known as hyaline bodies, can also be seen, and underlying connective tissue can also be seen with presence of proper collagen fibers arranged in a proper alignment with fibroblasts, and blood vasculature, that is endothelial line blood vessels, can also be appreciated within the dentigerous cyst, and inflammatory cells can also be seen. There is a proper cystic cavity which is being surrounded with this epithelium and surrounding fibrous or connective tissue stroma. Coming to the metastatic cancer, usually metastatic cancer, it is a condition which is usually occurring from a primary cancer or primary undiagnosed cancer, which usually progresses or otherwise which is being spread to other parts of the body through hematogenous route or otherwise disseminated route or from the lymph infiltration. So usually it is in a presence of any metastatic cancers. Usually it indicates that malignancy it is being undiscovered at its primary site, or otherwise it is usually an evidence of spread of the tumor from the primary site to the various other site, which is where the neoplastic cells or the tumor cells, they are being carried out through the hematogenous route or otherwise from the lymph route. So these are certain metastatic cancers which can be seen. Other than that, we also see that these malignant oral neoplasm, they only constitute the malignant oral neoplasm, they constitute only 1 to 3% of all the malignant oral malignant neoplasms. The primary source, it could be probably mostly from the breast carcinoma. It might reach to the oral cavity, or otherwise from the followed by the breast carcinoma, it is from the lung carcinoma, which might create or which might spread to the oral cavity, or then next commonly it is from the kidney or the renal carcinoma, which might result in the oral cancer involvement. And in the oral cavity, it is most commonly seen involving the mandibular molar region is the most common area for this cancer to occur. And these tumors, they are usually non-aggressive in nature, and they usually resemble that of the tumors which have given rise to it, that is to the benign lesion or otherwise any odontogenic infections. And usually in this condition we see that the secondary spread of the spread from other metastatic lesions, that is, it is most commonly from the lungs to the oral cavity. Coming to the metastatic casket, usually these tumors, they begin as a primary tumor, that is they might be from the primary side, and this from the primary side they might progress. As we know, malignant tumors, they have a property of metastasis and angiogenesis as the cardinal features. This metastatic property helps in transport of this tumor cells from the within the circulation to the secondary site of metastasis and result in the formation of secondary tumor, or otherwise known as metastatic tumor. So these are the stages of for the tumor to spread from the primary tumor, second systemic circulation, and finally to the final metastatic destination. So then usually the patients, they might complain with pain and dysphagia, difficulty in swallowing. Since it is most commonly the mandibular molar region which is being involved, they might cause difficulty in swallowing. Other than that, if the tumor is aggressive in nature, that is, if it is rapidly growing, which is a property of a malignant tumor, it might result in disfigurement of the face. And it might also, if it is a secondarily infected, like ulceration or otherwise trauma of this secondary tumors, it might result in intermittent bleeding can also be seen. And usually these are the tumors which spread from the breast, they spread to the jaw bones. If they spread from the lung, they might involve any soft tissue of the oral cavity. Among the males, we see that these tumors most commonly from the most commonly metastatic oral cavity tumors, they are being spread from the lung, followed by the lung it is a kidney, then it is a prostate, then it is a bone, and then it is a thyroid tissue. Whereas in females, we see the oral cavity tumors, they are being spread from the primarily from the breast, or otherwise from the genital organs, or otherwise from the bone, or any kidneys. So this is about the metastatic carcinoma and its spread. Coming to the histological features, usually these lesions they usually resemble that of the primary tumor. They that is if the patient has a well-known history of the tumor which has been treated, then if the patient gives a proper history, then we can correlate with the secondary tumor with that of the primary tumor. Suppose this tumor is not being recognized in the primary stage, then it cannot be properly definable. That is, histopathological features are not being properly definable. And usually gross specimen, it is usually distinguishable, that is, the metastatic tumor can be distinguishable from that of the primary malignancy. And coming to the treatment and prognosis, it usually depends based on the site and site of origin and degree of the metastatic spread, as well as based on the degree of the anaplastic features, which can give the proper prognosis of this patient. So this is what is about metastatic carcinoma.